Welcome to our webinar today. I'm Wafaa El-Sadr, and I'm the Executive Vice President for Columbia Global and a professor of epidemiology and medicine at Columbia University. I'm also a lead for the New York City Pandemic Response Institute. I welcome you to today's webinar, which is sponsored by the New York City PRI, which is an entity that has been established with support from the New York City Economic Development Corporation, New York City Department of Health and Mental Hygiene, as well as the New York City Department of Emergency Management. To tell you a little bit about PRI before we start, PRI is led by ICAP at Columbia University, a global center at the Columbia Mailman School of Public Health, and the PRI's key partner is the City University of New York, CUNY, School of Public Health and Public Policy. To tell you a bit about what PRI does and how it does it, it includes diverse partnerships with dozens of nonprofit, community, faith-based, as well as research and corporate entities that responded to COVID-19 across New York City and are committed to PRI's mission of having a citywide whole of society approach. Now, PRI is also committed to working hand in hand with all New Yorkers in communities across the 5 boroughs of our city to enable the development of locally tailored health solutions, information and resources to prepare for, respond to, and recover from future health threats. I want to also let you know that beyond the commitment, the deep commitment of PRI to New York City, PRI also aims to share the experiences and lessons learned with other municipalities in this country and around the world. Now, I'm going to move on to introduce Dr. Bruce Y. Lee, who is going to be introducing our speakers, our panelists today, and also providing an overview for the topic of our webinar. Now, Bruce Y. Lee is a physician and also has an MBA degree as well. He's a professor at the CUNY School of Public Health and Public Policy and Chief Technical Officer for PRI at CUNY School of Public Health. He's also executive director of FECOR and CATCH and has been an internationally recognized expert on outbreaks, epidemics, and pandemics for over a decade and a half, actually. Since 2007, he has been an investigator with the NIH Midas Network. This has included developing and utilizing mathematical computational models to help decision makers respond to infectious disease threats in the US for the past decade and a half. In addition, throughout the COVID-19 pandemic, Bruce has also continue to his modeling to inform decision-making in this country, in our country. He's also been serving at the WHO on the COVID-19 modeling technical advisory panel. In addition to all this work, he has published widely in academic literature as well as in the lay media. So I'm going to hand it over to you, Bruce, to introduce our speakers and provide the overview. Thank you.
Thank you, Wafaa. So welcome everyone to our webinar, our virtual webinar covering the transition that's going to be occurring on May 11th. So May 11th is going to be a big day because we're going to basically see the end of 2 national declarations of emergencies. So if we could move to the slide. So basically this webinar will cover the end of the federal public health emergency for COVID-19 and what does it mean? Because what we've been hearing all around are questions from all kinds of people, ranging from people from different sectors in healthcare, in different financial sectors, restaurant industries, transportation, you name it. And they are hearing of these ends of the COVID-19 emergencies, but it's not always completely clear what this actually means. So let's move to the next slide. So I'm just going to go through 10 things that are going to be changing come May 11th, or maybe soon after May 11th. And I covered this recently in a Forbes article, which I just wrote. And so next slide. So we're really talking about 2 major national emergencies that were declared back in 2020. So the first was a public health emergency that was declared at the end of January 2020. And this basically stated that this is a public health emergency. This came around the time that the WHO had declared this a public health emergency globally. So it was natural that the US declared this. And this type of public health emergency essentially expires every 90 days and needs to be renewed. So it's been constantly renewed since the end of January 2020. And the last renewal occurred 3 months prior to May 11th. So it's going to expire May 11th. So that's the first national emergency that's going to expire. The second national emergency is a general national emergency. Not specifically a public health emergency, but a general national emergency declaration. That was declared in March of 2020. And that type of emergency continues throughout the year and needs to be renewed by the president each year. And as all of you have figured out, this has been renewed each year, and that will also come to an end May 11th, 2023. So what's going to change with that? Well, first of all, one of the big questions is what's going to happen with these emergency use authorizations, otherwise known as EUAs. So a lot of the COVID-19 products like booster shots, treatments, various types of treatments, test kits, they are actually not under full approval from the FDA, the Food and Drug Administration, but they're covered by emergency use authorizations. And so one of the questions that comes up is, what's going to happen with these? Are these going to disappear from the market? So EUAs are going to probably continue until a lot of these products get approval, but that doesn't mean that these vaccines, tests, and treatments will be as available as they've been. So you see there's many cases where test kits have been distributed for free, vaccinations have been readily available. So expect these to go down because there won't be the same resources to really provide them generally to the public. So next slide, please. Secondly, COVID-19 vaccines, tests, and treatments may get a lot more expensive with less insurance coverage. So as all of you probably know, COVID vaccinations have been for free. So you basically can go to a clinic, you can go to any of these vaccination sites and get them for free. That's going to change as soon as the current supply is exhausted, because those vaccines were paid for by the government, and now you'll have to pay for these by yourself or through insurance. And we've already gotten word that, for instance, Moderna and Pfizer are going to significantly increase the price of these vaccines, potentially fourfold to $110 to $130 per dose. So the same thing might occur with tests and other types of treatments. And insurance previously was required to cover these things, and that may change with May 11th. Next slide. Another change is there may be a lot less information about what's happening with the virus, new variants, upticks, and surges. So you've already probably seen a ratcheting down in reporting. There's less information, and come May 11th, states and municipalities will no longer be required to report the results of COVID-19 testing to the CDC and other federal agencies. So we're probably going to get a lot less information. And next slide. And number 4, COVID-19 vaccination and other requirements will essentially disappear. So there was word from the White House that some of these last requirements, such as people from other countries traveling to the United States, federal workers, when it comes to vaccination requirements, those are going to disappear on May 11th. So the big question is, how is the virus going to be handled going forward? And number 5, so the healthcare worker shortage may get even worse. So we do know that even leading up to the COVID-19 pandemic, there were concerns about healthcare worker burnout, happiness within the healthcare, unhappiness within the healthcare industry. And we saw during the pandemic, with such an increased workload, a lot of stress and lack of personal protective equipment early on and during the pandemic, there's data suggests that a lot of healthcare workers, a lot of healthcare professionals are actually leaving their jobs and leaving the profession. So during the emergencies, there have been some stopgap measures, such as reducing the requirements or the credentials that are required for people to work in different healthcare facilities, but those are going to go away in May 11th. So big question is, what will happen with staffing shortages? Will there be enough people to actually see the patients that are out there? Next slide. And number 6, healthcare, surprise, surprise, could get a lot more expensive. So throughout the COVID-19 emergencies, there's been a lot of supplemental funding that have been provided to hospitals and healthcare facilities, including stipulations that Medicare has to pay certain amounts for people with COVID-19 diagnoses. Many of those are going to go away May 11th. So you have to wonder, well, who's going to then pay for a lot of the healthcare out there? And if you're a taxpayer or if you pay for insurance, a lot of that burden could come to you. So expect potentially healthcare services to increase in price. Next slide. And number 7, many people could lose health insurance coverage. So our panelists are going to be discussing this in the subsequent presentation. So I'm going to just touch upon this. There are stipulations with the emergency that states really couldn't change healthcare coverage requirements. They couldn't change benefit packages and those types of things for Medicaid. Well, that's going to change on May 11th and going forward. So you might see changes in who's actually covered by insurance and what that insurance will actually cover. Next slide. And various services may become less available. So one of the big changes and positive changes during the pandemic is we saw an increase in telehealth services, telemedicine services. Those aren't going to go away, but there are stipulations that came with the declarations that made it easier to do telemedicine. So easier to do telemedicine if you just had a phone rather than more extensive audiovisual equipment, or stipulations that telemedicine would be covered at the same rates as in-person visits. Some of those may change, some of those may persist, but expect some potential changes. There may be decreases in other types of services though. For instance, there was the stipulation that healthcare professionals could prescribe things such as pain medications over telemedicine. They didn't actually have to see patients in person, and that helped because there's many situations where people need pain medications, especially those struggling with addiction. The question is, will those services be available after May 11th? We'll have to see. Next slide. And number 9, this is, of course, a very important thing. There are many people who are still struggling with long COVID, and we expect to continue to see more and more cases of long COVID. And plus, those who are at greater risk for COVID-19 complications, the big risk is these groups of people will be left even further behind because there will be less attention paid to them. There's certainly going to be less news within the general media. And the question is, what kind of programs and what kind of support will there be for people who are struggling with long COVID? Also, when we're relaxing all of these COVID-19 precautions, that puts people who are at greater risk for COVID-19 complications at even greater risk. They're even more vulnerable. So what are we going to do about them? So we can discuss that during the panel discussion. And finally, number 10, research and other pandemic preparedness and response efforts could once again become neglected. So the Pandemic Response Network uses this, the Pandemic Action Network have used this term, the cycle of panic and neglect. And we've seen that over and over. When there's an emergency, then everyone says, okay, we've got to deal with this. What happened? How did this occur? And then once the emergency is done, then people have a tendency to forget about it and say, okay, let's move on to other things. Let's pay attention to pop culture or what have you there. And so the problem is we need to be fully aware that this could happen again, that outbreaks, pandemics, epidemics occur periodically. So what do we do about maintaining preparedness, maintaining a lot of the learnings that we've gotten from the COVID-19 pandemic? So with that, I just want to move on to the next slide and briefly introduce our next set of panelists. So we're going to see a series of 10-minute presentations from a number of experts, and we're very fortunate to have them present their viewpoints and key information regarding this May 11th transition. So first, you're going to hear from Jen Cates. Dr. Cates is a Senior Vice President and Director of Global Health and HIV at KFF. She'll be talking for the first 10 minutes. Then Rima Oken, who is a lawyer by training and has an MPH. She's the Director of Policy, External Affairs and Priority Populations at the Division of Disease Control at the New York City Department of Health and Mental Hygiene. She'll give a perspective, a city perspective in terms of what to do come May 11th going forward. Then we're going to hear from JD Davids, who's the co-director and Chief Strategic Officer for Strategies for High Impact Long COVID Justice. JD is going to offer important perspective on what are we going to do about people who are suffering from long COVID and the new cases that are going to emerge in the future, and what are we going to do about particularly vulnerable populations. Then we'll hear from Danielle Holahan, who's Executive Director at New York State of Health. She's going to provide insights in terms of what's going to happen May 11th, especially when we're talking about changes in insurance coverage, Medicaid, et cetera. And then wrapping it up, Johanne Morne will be, who's the Deputy Commissioner for Health Equity and Human Rights. She's from the New York State Department of Health, will be offering a state perspective in terms of what will be happening. So we'll get the local, state, national perspective, and a whole lot of other perspectives in the next set of talks. And then we'll have a Q&A. So please, if you have any questions, feel free to write them down, and we'll try to get through as many questions as possible during the discussion. So without further ado, I'd like to pass along the virtual microphone to Dr. Cates, who will be giving us important, valuable information about what's going to be happening nationally.
Great, thank you so much, Bruce, and thanks to the Pandemic Initiative and all the partners who are putting this on. It's so important. There's a lot of information and moving pieces. And for those of you watching, I think you'll hear a lot of specifics today. So what I thought I could do first is provide an overview of, in a sense, why this is so complicated. And if it feels complicated, it's because, go to the next slide. This is not just about what's happening with the public health emergency declaration ending on May 11th. The larger environment that surrounds it is very complicated because if you recall, when January 2020 arrived and it was becoming increasingly clear that we were in the midst of a once in a century type of pandemic, many different things were beginning to be put in place to try to address it. Click through, please. So in addition to the FPHE that was declared, and Bruce alluded to this, there were multiple emergency declarations that were actually declared by the federal government, as well as several states and some local jurisdictions. Next. There were also several pieces of legislation that Congress passed, each of which did different things to address aspects of the COVID pandemic, and in many cases to connect themselves to the declarations and provide, in a sense, protections for people in health systems. Next. Also, the two administrations that span the pandemic, the Trump administration and then the Biden administration, have taken several steps from an administration perspective to address some of the challenges. Not always to address challenges, but to do various things. Next. And then not all of the declarations that have been put in place are ending. So it's even more confusing about what's ending and why and when. Next. And some of the changes that are happening right now or will happen used to be connected to the FPHE, but no longer are. Bruce mentioned something really important that will come up later around Medicaid and the provision that Medicaid programs keep people continuously enrolled during the pandemic to ensure continuity of coverage. That used to be tied to the FPHE, that now was decoupled and has already begun. Next slide. And all of these interact with each other. So identifying one provision does not necessarily give you the answer. So if it feels complicated, it's because it is. Next slide. This just shows the major declarations that were made by the federal government. There were 5. They were made at different times. They have different stipulations, and they basically allow the federal government to waive their regular order of business to provide much more flexibility for, as I said, health systems, but also to protect people. Next. There were also, as I mentioned, several pieces of legislation. Can you click through? The main pieces of legislation that were passed that actually changed some aspect of access, coverage, flexibilities are listed here. They all have played a different role in this. Next. And importantly, both administrations have taken different actions that have made a difference. And one that I just want to highlight is that the federal government has purchased vaccines, tests, and treatments to provide free of charge to everybody. It's probably the only time in the United States where we had universal coverage of a particular area of health. And that's going to transition to the commercial market. But there have been other things that the administration has done to address the pandemic. So next slide. Oh, sorry. And the state and local declarations and actions, every state has had a declaration at some point and taken actions. And some of these have been tied to the federal FPHE, some haven't. Next slide. So the important thing to remember is that there's this complex environment. When these different things come to an end, some of which are ending on May 11th that you'll hear about, and some that are ending at a later date, these are the areas that will change. Health coverage, support for COVID vaccines, tests, and treatments, health system support, data reporting, telehealth, and nutrition support. There are others, but these in the area of health, these were the main ones. Next slide. Just to show how complex it is, this is something that we have a resource online, but this is a timeline that we developed to try to identify what is ending and when. And if you get a chance to look at it another time, you'll see that it's all over the place in terms of the next 2 years, what all of these changes will mean. Next slide. Just wanted to leave you with some other resources on our website that go into much more depth on all of these issues that you can, after this, you can hopefully look at and get more information. Thanks so much.
Great. Thank you. I guess I will just dive right in since we have a lot to cover. Good afternoon. My name is Rima Oken. I am from the New York City Health Department. I'm going to be providing a brief overview of the impact of the end of the public health emergency on COVID-19 related healthcare services. Next slide, please. My presentation will cover COVID-19 vaccines, testing, treatment, and care for long COVID, and telehealth, as well as access to COVID-19 data and information. I will go through each of these topics one by one, but the main change you will see throughout is that COVID-related healthcare is going to start looking a lot more like all the other healthcare we receive, which involves health insurance for people who have it and turning to our safety net healthcare system for people who don't. Next slide, please. Starting with COVID-19 vaccines. Vaccination is still the best way to protect yourself from COVID-19, especially severe outcomes like hospitalization and death. There is also good evidence that COVID-19 vaccines reduce the risk of long COVID. The CDC has put out new simplified vaccination schedule. I won't go into that now, but I want people to be aware that with this new schedule, for most people, vaccinated or not, they currently need just one bivalent booster dose to be up to date. COVID-19 vaccinations will still be free after the public health emergency ends, but we will see some changes down the road. So currently, all COVID-19 vaccines are purchased by the federal government, which is why they are free. However, we expect the vaccines to enter the commercial market sometime in the fall. When that happens, for people with insurance, including Medicaid, Medicare, and private health insurance plans, vaccination will still be no cost to them. And we don't expect that to change, as certain preventative services must be covered under the Affordable Care Act. But people should be careful to follow their health insurance requirements, as with any other care, to avoid out-of-pocket costs. So checking, for example, if your vaccination provider is in your network. For people without insurance, we still don't have the full picture. There is an existing program called Vaccines for Children, and this program helps ensure that children without insurance get their recommended vaccinations for free, and that program does cover COVID-19 vaccines. The federal government has announced what they're calling a bridge access program to help uninsured adults get vaccinated, but we still don't have the details of what that program will look like. Next slide. In New York City, COVID-19 vaccines are widely available at thousands of locations. The city will continue to maintain the Vaccine Finder website, which is how you can search for vaccination sites by location, vaccine type, and age group. That's vaccinefinder.nyc.gov. This page is available in multiple languages and also has links to external sites for appointments. The city's health and hospital system will also continue to provide vaccinations as part of their regular service delivery, and health and hospital services are available regardless of immigration or insurance status. One thing to note as far as city services is that the city's in-home vaccination program for people 65 and older and people who are homebound has ended. That ended last week. These folks can get vaccinated through their primary care provider now or use Vaccine Finder to find a location close to home. And people who are homebound who have other homebound health services may also be able to get vaccination through those regular services. Next slide, please. Moving on to testing. COVID testing also continues to be an important tool in our arsenal for reducing COVID-19. We still recommend that people should get tested if they have symptoms or exposed and to stay home if sick to protect others. With the end of the emergency, access to free at-home tests will become more limited. Insurers are no longer required to cover 8 free tests per month, and the federal government, who's been sending out tests periodically, which could be signed up for online, that service will also end. And importantly, though, Medicaid will continue to cover at-home tests through at least September 2024. As for provider-based testing, there may be a fee for this, which is already true and has been for quite some time. So again, this is the scenario where you will want to check with your health plan, see what the coverage is, see what your network providers are, and check if there's a copay for testing. Next slide, please. In New York City, we will still be offering free at-home test kits, and these are distributed at locations throughout the city, including libraries and parks and cultural sites while supplies last. I've listed here a website you can go to check for an up-to-date list of locations. There will also be opportunities for loaded no-cost testing through health and hospitals, our health department, and other safety net providers. For help accessing testing, you can call 212-COVID-19 and also check the websites listed here. I've also listed a website for the health department's COVID Express testing sites, which offer free rapid PCR testing. Next slide, please. So moving on to treatment and care. COVID-19 treatment is yet another important tool. It can greatly lower your risk of hospitalization and could save your life, especially if you are at high risk for severe disease. Paxlovid is the main form of treatment that we have. It's an antiviral medicine, essentially a pill that's taken for 5 days. Other treatments are available for people not eligible for Paxlovid. As with vaccines, oral antiviral pills will remain free while the federal supply lasts. So I've listed here the federal government's Test to Treat website. It's a locator tool where you can find locations where where people can get testing and prescriptions in one place. After the federal supply ends, oral antivirals will be covered by most insurance, but they may be subject to cost sharing. So again, it really comes down to checking with your insurance, seeing what your coverage is, and seeing what your out-of-pocket expenses may be. The federal government announced as part of this Bridge Access program that they will include assistance for the uninsured to gain access to Paxlovid, but again, we don't know what that will look like. In New York City, we also have what's called a virtual express care program through our health and hospital system, and they will continue to prescribe Paxlovid for free. You can access Express Care through expresscare.nyc or by calling 212-COVID-19. And just to note that Express Care offers many other telehealth services as well, so I encourage people to check out that website and see what services are available. Next slide, please. Okay. Moving beyond oral antiviral treatment, hospitalization and outpatient provider visits for care for COVID-19 are already subject to insurance and cost sharing. So there really won't be much of a change here, as this has been true for quite some time. People with or without insurance can be billed for COVID care as with other healthcare services. In New York City, people who are ineligible for insurance because of their immigration status can enroll in NYC Care for low to no cost health care services at our health and hospitals, facilities around the city. I've listed here the website, which you can use to find out more information and to enroll. And you can also call 646 NYC CARE. Next slide, please. Addressing long COVID is a critical part of our city's recovery. So long COVID describes a host of different symptoms that people can have for months or longer after having had COVID. Long COVID is a new condition and we still have a lot more to learn, but we know the impacts of long COVID can be devastating for people with the condition and their loved ones. And our next panelist will be speaking more about that. But coverage for long COVID is treated like any other health problem in that insurance will be billed and medical care and medication may be subject to cost sharing. We have 2 health and hospitals programs in New York City that helps people with long COVID, and these programs will remain after the emergency ends. First, we have what's called our aftercare program, which connects people to health and social resources to help them in their recovery. This could include help getting access to medical care and mental health resources, help accessing food and financial support. Health and Hospitals also has 3 COVID-19 centers of excellence, which are facilities that specialize in long COVID treatment. There's one in the Bronx, one in Queens, and one in Brooklyn. For help connecting to these programs, again, that 212 COVID-19 number. There's also other long COVID specialty sites around New York City. The link I provided here on this slide lists some of those sites, and certainly our hope is that all providers learn about long COVID, become knowledgeable, and that they are screening their patients and helping them access the resources that they need. Next slide, please. So with telehealth, with the end of the emergency, there are some changes that we're going to see with regard to telehealth. Telehealth was greatly expanded during the emergency to enable people to continue to get care, especially in those early days when everyone was staying home as much as possible. With the end of the emergency, certain protections with the federal government put in place will end. For one, there was some flexibility around technologies that could be used with telehealth. And actually, I have a late-breaking update to my next bullet here, and that is with regard to the prescription of controlled substances through telehealth that the federal government announced just late yesterday that, in fact, they are going to extend this rule while they can put more permanent rules in place. So that's good news. Also an example of how the situation is constantly changing. Importantly, expanded telehealth coverage under Medicare will continue through December 2024 as well. And in New York State, we are lucky enough to have some permanent protections in place to help people in the state get telehealth. There's a parity law, which basically means that health insurance must cover telehealth in the same way that they cover regular services. And there was also a change made during COVID that was made permanent to allow services for telehealth that are delivered audio only. So that's also helpful to enable reimbursement for telehealth in New York State. Next slide, please. And finally, I just want to briefly go over access to information. So the federal government, the state, and New York City will continue to provide information on COVID-19 vaccinations, variants, and cases. However, there may be reduced frequency of reporting and data may be less complete. But this has already been true for some time. For example, many people using home testing, we know that our data regarding cases is not complete. However, we still have many, many core systems in place to track COVID-19, so we are prepared to respond if anything changes. These systems include case and hospitalization data about urgent care and emergency room visits, COVID-19 variant testing, wastewater testing, data from other states and countries, and scientific studies. And the health department is going to continue to monitor all of these data sources, and we will update our guidance and public health interventions as the situation changes. Next slide, please. So that is all I have. Thank you very much for your attention. I have our hotline number up there. If you remember nothing else, that's the number to remember, and they can really help answer your questions about where to access care if you need some help with that. And I look forward to taking your questions later. Thank you.
Hi, good afternoon, everyone. My name's JD Davids, and I'm coming to you today from my home in the unceded Lenape Canarsie land known as Brooklyn. I'm the co-director and chief strategic officer of Strategies for High Impact, which runs Long COVID Justice, a national network that also includes our local chapter, Long COVID Justice NYC. Next slide. Since we're after long COVID justice, we have a lot of work to do. So we do hope that you will join us. And I'll have a slide up about how you can do that in a moment. So I'm here to speak about how, even though a public health emergency is ending, pandemic harms are chronic, giving you some perspectives from elders meaning people of any age who have certain wisdom because of the nature of living with chronic illness and disability. Next slide. This is how you can join our information action network for long COVID justice, tinyurl.com/join long COVID justice. So I hope you'll take advantage of that today and moving forward so we can work together to rectify some of the issues that are coming up today. Next slide. I've been a HIV activist for over 30 years, while also living with complex chronic conditions, including myalgic encephalomyelitis, or ME/CFS. The CFS is the misname of chronic fatigue syndrome, which about half of people with long COVID may now have. And I'm also living with long COVID. I helped to start Strategies for High Impact to crystallize work many of us have been doing before and during this pandemic as chronically ill and disabled people. We're building the power of chronically ill and disabled people to care for one another in a society that often doesn't really care much for us, to create and share the information we need and the perspectives we need to be heeded, and to fight for the policies and programs that help us and our communities have healthy, safe, and dignified lives. So here we are at a crossroads, that's a crossroads, as the latest, the most definitive end of a series of endings is upon us. So I'm going to start out with my bottom line understanding and my request. Pandemics are chronic, and so is injustice. True health equity will never come without uprooting ableist narratives that treat chronically ill and disabled people as exceptions and as expendable, whether that's on May 11th or on every day of every week of every month of every year. So we're calling for a transition from a public health emergency to public health resilience that centers chronically ill and disabled people. So my ask for you is, when we aren't named, name us. When a policy is proposed without considering the impact on us, demand or do an impact analysis. Most importantly, insist there should be nothing about us without us. And that most urgently means Black, Brown, Indigenous, and queer and trans people facing the most marginalization and bias when disabled and chronically ill, as well as the highest rates of disability and chronic illness. To summarize where we're at with long COVID before moving on, there is virtually no comprehensive, competent care available to people with long COVID in the US or anywhere, however, relative to the huge need. However, as my colleague just explained, there is some care available in New York City. And we need it to be better publicized, and we need it to be recognized that while it's said there's no treatment for long COVID, there's lots of treatment for some of the symptoms and for some of the conditions that can be found in long COVID, and you deserve care. If you suspect there is something going on that's different for you in your body or in the body of your child or friends or family, seek out and get care, and continue seeking until you get care that's helpful to you. You have a right to diagnosis and treatment, and it could start with care at the centers of excellence that were already described. So at this crossroads, we have a decision to make. Next slide. Are we going to approach this moment as we have in the drastically successful effort in the HIV/AIDS crisis on the left, where a coordinated, resourced federal to local framework of research, funding, and programs turned a near universally fatal condition into something where people can live a normal lifespan if they have access to care and treatment and support? Or are we going to go the route of ME/CFS on the right side, myalgic encephalomyelitis, which I'll remind you half of people with long COVID may have, which affects 1 to 2.5 million Americans even before long COVID, and is most frequently triggered by viral infections. The average person with ME scores as more disabled on quality of life surveys than those with multiple sclerosis, stroke, diabetes, renal failure, lung disease, heart failure, and cancer. Yet we have virtually no research, no national plan, no significant programs for training providers, no funding for the care needed, and virtually no progress in treatment, care, diagnosis, or for decades, let alone having the wraparound services we found to be vital in HIV. This is what medicine as usual means for people with complex chronic conditions. So next slide. That's why we want you to join us in calling for a comprehensive interlocking response to long COVID modeled on the potent trio of the National HIV/AIDS Strategy, the National Institutes of Health Office of AIDS Research, and the Ryan White Care Program, the reach of all of which has been improved and extended by resources and innovations from New York City and state. But New York City and state needs federal help to tackle the long COVID crisis. We realize there's big differences between HIV and long COVID, but we were among the first to call for looking at the HIV model to adopt and adapt what we need for long COVID crisis. Next slide. Long COVID affects well over 100 million people worldwide, and by this time, probably over 1 million in New York City alone. In an analysis of workers' comp claims that I'm not going to detail for you, but they're on this slide, things were looking bad for New York's workers. In an analysis from the State Insurance Fund, there's drastic impacts, and there's been multiple instances of showing the economic impact of long COVID. But the impact leaves out that which isn't documented, which is the many workers in New York City and state who aren't eligible or don't apply for these insured services. So even with the shocking and ongoing death rates we've seen with acute COVID, some models have revealed that long COVID, which can include short and long-term disability, and yes, fatalities, including among young people, will likely overtake acute COVID in terms of cumulative mortality and morbidity. And bear in mind, for example, of many of what this means. COVID infection itself brings a 10 times increase in risk of death in the following year. Next slide. And we're now officially saying it's okay for people to get COVID over and over. Even as we approached May 11th, we've been in a downward trajectory of COVID-related demobilization that started far before this deadline, as Jen detailed. The chipping away and slashing of protections, funding, and interventions brings many unanswered questions and risks for our communities that we frankly don't hear a lot of answers about. So as you hear about the impact of the end of the PHE, I hope you'll join me in centering these two important overlapping constituencies. People with long COVID, which includes people like me who were already chronically ill and disabled before long COVID got added into the mix, as well as those newly dealing with illness and disability, and people at ongoing high risk of COVID harms, including immune suppressed, the elderly, and those with many common comorbidities. And many of us are in both groups. For example, people with diabetes face higher risk of more severe COVID and have approximately 4 times the risk of getting long COVID, as do people with HIV. So I ask you to pause for a moment to consider, have you heard, read, or seen any significant spotlighting or shifting of resources or focus to these constituencies as we approach the official end of the public health emergency? We see like throwaway sentences or clauses here and then that there's some remaining sort of communities that may have some concerns or risks from COVID, but what we don't hear is what's there for us, and there's very little. So let me be clear. There's some very specific things that we do need to happen. We need to be able to get medical care with people wearing effective masks. People who are disabled and chronically ill, who are staying at home to preserve their lives, should not have to risk those lives going into settings where we go to get our care, where we know we're at greater risk of airborne pathogens if there's not universal masking. That's just one of many examples. Long COVID Justice is seeking support for a planned patient-led needs assessment and action plan on long COVID in New York City. As we've seen in HIV, and since the early days when long COVID was named by patients ourselves, we know that research and advocacy designed by and centering those most affected makes a real difference. So next slide, please. When our needs of those who need protections after the PHE, we're the many, not the few. Even if we look at about 3% of people are profoundly immune suppressed in the country. We know that we have seniors who are about people over 80 who are at the highest risk of COVID is about 13 million people in the United States. All of us who are chronically ill and disabled, even if we're not at documented elevated risk of severe COVID, we may be at very severe risk if we get one more blow against us that will make us even less able to work, to care for our families, to live independently, or have the future that we would all like to have. We are very much at risk. And now, of course, people with long COVID. But of course, this is an airborne virus. And that means that everyone we live with, travel with, work with, or go to school with is still in this web of affecting our lives, where they, if not utilizing COVID mitigation protections that are going to become harder and harder to find, and they've been told they don't really need, are a risk to us. Next slide. So that's why, since there's so little resources available, one of the things we've made at Strategies for High Impact is called practicing inclusion in the time of COVID. Tools that are on Instagram and internet help people understand the importance of maintaining and establishing safer practices in order for us to be able to become and stay a part of society, frankly. So these are the things that we need as the identified 10 to 15% who in polls explicitly are trying to maintain COVID protections. Now imagine what that percentage may be if people had accurate information about the ongoing risks of long COVID to themselves and loved ones, including disability from long COVID. And if we counted people who wanted to prioritize COVID protection, but have never really been given the means to do so, like effective masking and instructions on how to integrate them into life, or the many city workers who could be working from home, if not for the mandates of the Adams administration, and so on. Next slide. So I need to wrap up. I will tell you that in the slides coming up are some examples of what we are asking people to consider. There's many examples of how people at highest risk are affected by the end of COVID protections. Think of the relationships that we can't maintain. How can we deal with people, date people, or marry people, or have kids with people if we are at risk from them? Lifestyle and generation changes, including kids in schools, families in intergenerational housing, and access to essential care and services, like the fear people have now of basic medical care, and that the exacerbation of the home care crisis that's the most severe in New York State, even before the drastic expansion of need due to long COVID. So I'll wrap it up for there, but we can do the impossible again. People used to say that we could never have HIV treatment in Africa or poor countries around the world. And we made that possible. I was part of, many of you were part of making that possible. It's possible to mitigate COVID, and it's possible to have COVID vulnerable people rejoin society. We need you to join us in fighting for that. Thank you.
Thank you. Okay, so I'm Danielle Holahan, as was said at the beginning. I am the Executive Director of New York State of Health, which is New York's marketplace. We were established in 2012 under the Affordable Care Act. And through New York State of Health, New Yorkers can get Medicaid, Child Health Plus, the state's basic health program, which we call the Essential Plan, and qualified health plan coverage. It's been said, I think, a few times that the public health emergency has been delinked or the continuous coverage requirements have been delinked from the end of the public health emergency. It's a better way of saying it. And I want to talk about the activities we have underway at the health department to ensure continuous coverage for as many people as possible as we unwind from these requirements. So if you'd go to the next slide, just quick way of background here. I think, again, it was said, but I'll repeat it. During the public health emergency, there were requirements that states kept individuals enrolled in Medicaid continuously covered throughout the emergency. New York elected to extend those requirements to our basic health program or essential plan, as well as our Child Health Plus program. So that meant nobody could lose coverage. Nobody had to do the annual renewals or redeterminations of eligibility as we have outside of COVID periods. So we were following the end of the public health emergency until December, when it was officially delinked and different rules applied. So the continuous coverage requirements ended at the end of March. And then states had to develop unwind plans, which is what I want to talk to you about today. A key date, I will just say for folks listening, is that while it ended at the end of March, New York, and I'll walk through this, but nobody in New York will lose coverage before July 1st. And we hope nobody loses coverage at all. But I'll walk through how we're approaching this and the timeline. But I thought it was important to put that date out there. Okay, so the next slide is just a chart that shows the coverage gains that we saw during the public health emergency. So in March of 2020, across the three programs that I'm speaking about today, we had 7.3 million people enrolled in coverage, primarily Medicaid, but also our Essential Plan and Child Health Plus. As we extended everybody's coverage and took on new individuals, nobody lost coverage, and we gained 2 million lives. So we are now at 9.3, or actually a little higher today, but around 9.3 million individuals enrolled across these programs. And we were proud to be a safety net for people who lost income or jobs during the emergency, so that everybody had access to coverage. But here we are with the 9.3 million, and we are required now to start redetermining everybody's eligibility and transitioning them into the coverage that they are now eligible for. So the next slide, and I'll just mention numbers wise, this is half of the state's population. So this is a huge undertaking, and there's been a lot of energy that's gone into how we will do it and how we will do it well. So the slide here, I'll just highlight a few points, but there are a number of federal requirements around how states do this. A key theme, a key theme of these requirements is that consumer comes first. The very much focus on the consumer and people keeping coverage. One of the requirements is that we are encouraged to evenly distribute these renewals. 9 million would be a lot to do in a single month. We embrace that. We will spread the renewals across the maximum period of time. So that's over the course of 12 months. Another requirement is that states must not terminate anybody from coverage until they have done a full redetermination or a full renewal. And the maximum amount of time a state has is 14 months. That's actually what we're taking, with the 2 months in advance to get notices out, and then 12 months for each cohort. So New York is taking as much time as we can to do this right. And finally, I'll end with the goal, which we share, is around keeping eligible individuals enrolled, reducing churn that you typically see or often can see, and maximizing transition to other coverage as appropriate. New York's marketplace, New York State of Health, is fully integrated across these programs, so that helps us to transition people into different programs if we determine that they're no longer eligible for Medicaid. Okay, so the next slide, I'll just walk through quickly. It's actually one back, sorry, on the challenges. The challenges to winding down coverage. The numbers for sure are challenging. I mentioned the two buckets of consumers, those 2 million who were new to us during the pandemic, and then those who have had their coverage extended for 3 years. We have different messaging that we want to get to those different cohorts to make sure everybody knows what to do and when. But people who were new to us during COVID have never had to renew before with the state. So this different kind of messaging that we'll need to do. There's other activities that we've been undertaking to be ready. We've been updating all of our eligibility and enrollment systems. We and local district offices across the state have been increasing staffing levels. Staffing levels were down during the pandemic as coverage was automatically extended, but we are ramping that back up, and we're restarting all of our notifications to consumers. And then importantly, we have an enormous public education and outreach effort underway to make sure people know what they need to do and when, and importantly, who to contact. The next couple of slides, maybe we could just move through quickly. This is just showing how the enrollment distributes across New York's marketplace and the local districts. The next slide talks about within the local districts, how they distribute in New York City and upstate, but we can move through those. I'll flag maybe one point on this slide, and that is one of the easements that we are allowed is 1 million individuals in New York who are on cash assistance can be automatically redetermined. So that brings our 9 million down to 8. So I just want to mention that. And there are other easements that we have been permitted that will allow us to maximize how much we can automatically renew consumers. So wherever possible, we will try to redetermine people automatically with the goal of keeping people covered. So this is showing our timeline. So we actually began in New York in March in New York City, starting to send notices out to consumers who needed to be redetermined. The upstate local district offices have been sending the renewal notices since April, and New York State of Health will begin in May. But everybody The very first group of individuals who will be redetermined are those whose coverage ends at the end of June. And we will be taking a cohort every month across this 12-month continuous coverage unwind period, June of 2023 through May of 2024. Roughly 1/12 of our population will be redetermined each month, and that's to smooth this out, make the caseload manageable. And so we're getting these notices out to consumers, telling them what action they need to take and by when, to make sure they keep their coverage. This next slide is one of the education materials that we have created around how to renew your coverage, where we walk through a hypothetical consumer named Michelle and walk through the steps that it takes to keep her coverage. So we first talk about Michelle receiving her renewal notice in the mail, and it's telling her action she needs to take and by when. It also tells her in step 2 different ways she can get help, whether it's through our website, newyorkstateofhealth.ny.gov, calling to connect with an enrollment assister, and that you can find on the website or at this customer service center number. The next step would be Michelle finds out she needs to update certain information in her account in order to keep her eligibility. She works with an enrollment assister, and she's able to successfully renew her coverage. So we hope it's this easy for everyone, but we want to make sure there's different ways people can get help. Next slide. There's a lot we're doing around tracking how we're doing and reporting this out. There are requirements. The federal government will be tracking this across all states, looking at the numbers of renewals, where people move if they leave Medicaid eligibility and move into another program, and then volume of eligibility appeals. So that we'll be reporting, we'll be sharing that publicly. And then we have a series of dashboards for our own benefit, operational dashboards, so that we can track how we're doing and where we need to focus energies. So that refers to consumers that need either a manual, meaning they have to take action to keep their coverage, or administrative renewals, so we can focus energies on those who have to take action. We want to look at our statistics across demographic characteristics to see if there's certain cohorts of populations that need extra attention. Also tracking the transitions between programs. And then of course, a big focus is on undeliverable mail, because we know a lot of people moved during the last few years, and we want to make sure we're on it and we have other ways to reach them. So the next slide is just a visual of the dashboards. This is all hypothetical data, but these are going to be interactive, so we can dig in on a county, for example, or a different cohort of the population to see where attention is needed. Then we'll be tracking this in real time. We can move to the next slide and then the next one. I just want to mention a few other things before I run out of time. We have over 7,000 enrollment assisters in New York across the state who do work to enroll. In typical times, more than 3/4 of our consumers enroll working with an assister, and they have been trained. They have very helpful dashboards to help them identify the consumers who need help, and they will be available to help with this effort. I'll run very quickly through a few of the education materials and all the communication, but these slides will be shared, and these are some important links around our advertising and education materials. You can move to the next one. Our materials are all available in 14 languages. They're listed here. I list a website that we continue to update as information becomes available, and includes key points about what consumers can do now, even if it is not their time to renew, which is largely around updating their information and making sure we have their up-to-date contact information. And then it also has a lot of how-to videos and things of that nature, so they can find out when it is their time to renew. So you can move. We have a lot of links here about the pages on our website and the Medicaid website. You can go to the next slide around where this information is posted. And then we have a very, very robust toolkit, if you want to go to slide 18, that has a lot of materials that if you all work with go to the next one, thanks. If you all work with consumers and you want to share some very quick information about what people need to know and what they can do, there's a host of materials here that we want to make available for anyone to use. So take a look at that, help us spread the word. And then finally, there's a few slides in here around some of the messaging. We've actually been advertising for over a year, trying to get people's attention to update their contact information, make sure we have the right phone number so we can text them when it's time to renew their coverage. And then finally, as of last week, we moved into our last phase of our ad campaign, letting people know that we are in this renewal period now. And when you hear from us, it's time to take action to renew your coverage. So those ads are live today. And then this one, we don't have to play this, but this is one of many videos that we have about how people can update their information. So we're trying to make it easy, but our goal really is to keep everybody covered. We like we have made a lot of strides even before the last few years in cutting the state's uninsured rate. And I expect that because we added 2 million lives to coverage here, we have fewer uninsured. And obviously, given all of the great needs that everybody has talked about, we want to make sure people have health insurance coverage and can access the care that they need. So thank you for your time. And I will turn it to Johanne.
Thank you so much, and good afternoon, everyone. I'm glad to join you and really grateful for the invitation to talk about vaccine equity and some of the tremendous actions that we were able to take through the COVID-19 response. So one of the joys of going last is that you get to hear from your colleagues and you get to build upon what they've said. And I think that there were so many statements that absolutely resonated with me. But I wanted to take one statement that JD made, and that was about talking on the fact that, during the COVID-19 response, there were so many things that we had always been told were impossible that became possible. And so I want to talk a little bit for the next few minutes about the fact that what we learned as it relates to access, as it relates to the ability for people to have the information they need to make informed choices, to ultimately lead, hopefully, to vaccination, that along the way we have lessons. And if I leave you with nothing else today when we talk about equity, I hope that what I leave you with is an understanding that we have to take the lessons learned from every experience we have, because in fact, that is what allows us to grow, and that is what allows us to utilize the most effective evidence-based responses should we find ourselves in another response. Next slide. So this is a slide that may be familiar to many of you, and this image certainly is one that speaks to equality and equity. And one of the things that I often hear is individuals using these terms interchangeably. And what I want to make sure we talk about, and in this example for the purpose of today, and speaking of vaccination, there is one thing for there to be availability. It is something else for there to be accessibility. And so when you look at these two images on the left, what you see is that any of the fruit on the tree is available. And in fact, every single person was given some type of resource or tool to make that reach. But the nuances and the uniqueness of each of those individuals was not taken into consideration, which means that while available, it wasn't accessible. And when you look at the image to the right and you see that there were tools given based on the identified needs and what we learned from the individual of what would allow them to be able to access and reach the fruit on the tree, we created for them an opportunity. So equality, equal access, is not equity. And I certainly think that throughout the COVID-19 response, what we recognized here in New York State and across this nation is that we have to be intentional about how it is we want to reach people in order for individuals to be able to access what is available. Next slide. So what did we do in New York State? I think that what we did certainly was build upon a framework that had already proven to be evidence-based. I know that my colleagues talked about some of the other responses that we've had as it relates to public health over the years. And if we look at the frameworks of what has worked in the past when trying to create public statements with the intention of ensuring public health, then we created a framework that looked at building recommendations from individuals with expertise and individuals with lived experience. And so that means including our community-based partners in the conversation up front and helping us develop the steps that will allow us to have the best outcomes. So in New York State, during the response, we had the Vaccine Equity Task Force. And this is an example that we use through all of our public health responses, but in this particular example, looking at the specific steps, we launched a task force in December of 2020. We took the opportunity to work with individuals who had lived experience in the community, who were knowledgeable of community partners and community members, and who had expertise that would allow us to understand how best can we make the vaccine accessible, not only in the form of the actual vaccination, but in the form of education, awareness, and understanding. And so this task force had guiding equity principles, and what you see here is exactly what we've seen has been successful in the past. So first, identifying and speaking intentionally, clearly, and directly about the challenges that we would face. And when we talk about issues around equity, then certainly we have to address the longstanding challenges and barriers that racism and structural racism has presented to us and to the people that we serve. And so as we thought about a COVID-19 response, how did we address those historic structural racisms and those existing patterns of behavior and policy that would interrupt or disrupt our ability to be successful in reaching people? We had to talk about health literacy as well as language access, understanding that, as shown in one of the previous slides, we had to make sure that information was being presented in a way that people could understand and that people could relate to. We have to make sure that policies ensure protections, as well as making sure that communities and community partners are at the helm of the work that we do, because we know from previous experience, lessons learned, that community-based organizations have a greater ability to engage individuals. Why? Because they already have an established relationship of trust. And if you go on and look at the remaining 3 points as far as the guiding principles based on equity, engaging with community-based partners, creating public service announcements for the intention of education and awareness, and developing community engagement resources so that we could reach across all communities, and in particular prioritizing those communities that were most at risk and most vulnerable. Next slide. So enhancing community trust, which I mentioned in the previous slide, and what we want to do again is making sure that we are engaging with our community partners in a way in which it can be meaningful. And we know, and through our response, that the mistrust of government, the mistrust of a novel pandemic, and the mistrust of vaccination certainly contributed to the challenges that we had as we were looking to engage people in prevention activities. And so for us, a big part of it was taking what we understood from the science and from the medical community, making sure that we were delivering those messages in a way that individuals could understand and that individuals could also take and repeat to other members of their community and their households. We went from looking at data and numbers and making sure that the analysis and the transfer of that evidence-based information was done in a way that represented people. So it was understood that the number was representative of someone and so that is meaningful. And then we went from making sure that we didn't just have vaccine in hand, but that we had vaccine in places where it could be accessible. And oftentimes through this response, as well as through other public health responses, we will hear our colleagues sometimes say that individuals are hard to reach. I want to challenge that notion by suggesting, as another colleague of mine did some weeks ago, is it that individuals are hard to reach, or is it that services and resources are hard to access? And so the image there you see of that mobile unit is about bringing the resource or the tool to the community, to the individuals that we are trying to reach. Next slide. So I mentioned before the purpose of using data, and data certainly is an extraordinary tool that we have that allows us to make informed decisions about where the most need and risk is. And so for us here at the state, using indexes such as the SVI, the Social Vulnerability Index, looking at zip code data so that we could look into communities on a very detailed level to understand what our vaccination rates were, what opportunities there were to engage more people, and where we needed to really strengthen our community partner base so that we were reaching out to individuals, again, in environments and areas in which they felt comfortable and trusting. Our work across the state with faith communities was one of the most exceptional ways in which people were engaged, recognizing again there that there's already a pre-established relationship. And when leaders that have trust in the community are able to speak to what they have found, we as government and those in the medical community are able to offer, it certainly helps build a bridge. But I want to go back to the point of data. Again, one of the lessons learned through COVID, again, and not unique to COVID, but sort of reinforced, if you will, by COVID. We have to make sure that we are collecting meaningful data, intentional data that is able to describe a whole person. So looking at gender, looking at age, looking at other demographics and distinctions that allow us to understand who we're serving and who we still have yet to reach. And then making that data available back to the community so that communities can know as well what it is they can do to continue to provide protection. Next slide. So what will happen to services after May 11th? All my colleagues certainly talked about this. And what I want to say is that after May 11th across this state, as indicated in many of the presentations you've heard today, is that we take the lessons learned and we continue to build and move forward so that if we find ourselves in a position of needing to respond to a public health, I hope not pandemic, but emerging issue or crisis, that we are better prepared so that we don't lose the lessons learned. When we talk about health equity and we talk about vaccine equity, COVID did not create the disparities that we experienced. What COVID did was simply, again, give evidence to the fact that individuals who are vulnerable, communities that do not have the same level of access, and opportunities that perhaps have been missed for us to build true bridges to healthcare. It gives us this path forward, if you will. This is a result of an absence of social determinants of health. It existed prior to COVID, through COVID, and still continues to exist today. So what will happen to services after May 11th? As indicated before, certainly grateful for New York State in that we always do our best to make sure that people have access to the insurance and the care and the protection they need. At the same time, we have to make sure we take the lessons learned and that all the things that were once impossible that became possible through COVID continue to allow us to advance forward. Next slide. And so in closing, what I would say is this. Once again, we are faced by a very significant change. The end of federal health emergency is significant and certainly results in change. Our responsibility and our ability is to make sure that we are communicating those changes in a meaningful way to the people that we serve and the people that we love so that people can make informed decisions. And at the same time, maintaining the resources that we were able to gain access to, such as telehealth, as an example, that we realized made a significant difference for people. We have the ability and the opportunity. Now we have to move forward together. Thank you.
Okay, thank you, Johanne. I'd like to invite all of the panelists, all the speakers to come and join our panel, our Q&A panel, to wrap up this session and basically address some of the questions that have been coming through the chat. So one of the questions that I've seen, and it's come in multiple iterations, is that there's an emphasis that the COVID-19 pandemic is not over. The SARS-CoV-2 virus is still spreading, and so the emergency is ending, but there's also new variants that are continuing to emerge. There's always the risk that there's going to be upticks and surges, et cetera. So multiple people have asked the question, what's going to happen after the emergency with potential upticks, surges? Will there be the ability to respond and prevent these surges? What's going to happen with mask requirements? What's going to happen potentially with vaccines? What's going to happen with other types of precautions? So wanted to throw that out there. to see thoughts on how the end of these emergencies may change the potential response.
I'm happy
Jen?
to, yeah.
Oops, Jen, you're on mute.
There. There's no question that if there is an uptick, or when there is an uptick, or even a surge, that we're just going to be less able to manage it. That's just because we'll have less flexibilities, less resources, less awareness, and also less visibility into those trends because there'll be less data. So I think I saw those questions come in. I think those are the really important questions to ask. What will it mean? I think a question in my mind is, if things get really serious at some point, is the public going to support, and is the federal government going to move back towards reinstituting some of these flexibilities or requirements? I think that's going to be a tough thing to happen politically, but I do think that we're just going to have less capabilities for responding as COVID continues to have impact, and it will vary based on where you live. I think for those in New York City, you'll probably be in better shape than some other parts of the country.
I can add to that. For New York City, I think, as I noted, we still, we do have a robust surveillance system in place that predates COVID, right? We've been tracking infectious diseases, cases, hospitalizations, clusters for a long time, and we're experts in that, and we will continue to be. We've had to adjust changes in data throughout this. We've had, once I mentioned before, once home testing became so big, we knew we weren't going to get even close to 100% of the cases, and in fact, by some estimates, less than 50%, because people aren't being tested in healthcare facilities. But we're able to use the data we have. We're able to use modeling. We get great emergency room and urgent care data, which is called syndromic data. So I think together we are in good shape to identify if there is something coming down the pike that we need to respond to. We looking at the Omicron surge, we had some time, not enough, but it's never enough to prepare. When we heard that this was coming, out of when it was first identified in Africa, and it gave us some build time, and we were closely monitoring the data. We've been fortunate that the new variants that have come out have tend to be often more infectious, but haven't been causing more severe illness. There's always a possibility that can change, but I do think the systems are in place to monitor it. I think that what we really need to be careful of is looking, way down the road, is when emergency funding ends, right? So we were given so much funding to build up, all these contact tracers and other arsenals of to respond to a pandemic of this proportion, and we know that amount of money won't be available in the future absent an infusion of more. So I think we really need to think about sustained public health funding, but we do have a robust surveillance system in place.
I would, even though we're not going to have the amount of funding we've had, I would encourage all of us to figure out what we can do for preparedness. I think that part of the answer to the question is, what will people already have on board? Like when you're in the middle of the flood, it's not the time to have your go bag, start packing your go bag. So I can say in a household of disabled and chronically ill people that we've been given nothing to prepare for the future. We should have preparedness kits for every family, but especially for those who are already in systems of care for comorbidities like HIV, diabetes, in elder care, and in congregate settings. So we're ready to go. I have my P100 mask here, but that's not everyone can buy that for $45. So the city has not had and state have not had a comprehensive way to get high quality multiple masks to households in a consistent way. And it's not necessarily the fault of the different levels of government that there's been shifting abilities to provide or have funding for services, right? But what I hope is happening behind closed doors, or pray for, is that these kinds of discussions or preparedness are happening to be able to use any available resources to resource existing neighborhood-based and community-based groups that know where their folks are, to be able to get things in people's hands, to say, when we give you the sign, that hopefully we'll have a sign from any kind of monitoring. If you aren't able to consistently have safer practices, that this will be the time to do all you can to amp it up. I think there's a lot we could be doing in advance. If we don't do it in advance, the surges are happening now for basically our people, right? Because of the level of vulnerability. There's not a low level happening of suffering. And so if we don't get people ready now, that's going to spread out further.
Yeah, so JD, you mentioned masks, and so there's a number of questions in the chat about what to do about mask requirements or people wearing masks. Someone raised the question that, or the point that some people are afraid to go to healthcare settings now that there aren't universal mask requirements. So I guess the general question to everyone is, one, how should people approach mask requirements or mask recommendations? And what there seems to be a bit of a dichotomy, or even more than a dichotomy, where some people are saying that, okay, we really need to continue mask requirements, especially for those who are vulnerable. And the other end is there's, you can go to places and you can see no one wearing masks. So what are the thoughts about, how to approach this, and not just how people can approach this individually, but what should we be pushing for, the federal government, institutions, organizations to be doing about face masks?
I think one thing it's important to recognize is that there's a concerted misinformation, disinformation campaign about masking from people with both vested, interests and ill intentions. The Brownstone Institute, that funds conservative fellows, believes that we should go back to pre-Reconstruction policies, and they are part of the impetus that was behind the Cochrane review that purported that masking doesn't work. Masks definitively work. They can be observed through airflow. You can test them empirically. What needs to be put in place is systems that allow people to integrate them in their lives and understand why they're doing it. The population has been led to believe that one-way masking is sufficient, including in materials provided by the state, for example, on MTA. And so this has hurt public concept. And so education components are a key part of this, but also the provision of making masks available and mandating where people have to be. People need medical care. We need to be able to get it safely, but people need to understand it's not safe for us if you're not wearing a mask. They really have not been told that, and they haven't been explained that. So it's very important to do both. Every time someone sees someone with a surgical mask walking around the street, there should be outreach workers who give them K95 masks, give them 30 K95 masks, because they want to mask. They are masking, but they're not masking effectively. So we need to have resources in place and systems that give people effective masks who are masking.
Thanks, JD. Any other thoughts about face masks?
I mean, I can say for New York City, our guidance, we're trying to give some simple rules of the road, recognizing nothing in COVID is simple. There's certain times people should always wear a mask. If they're sick and they have to be around someone else, they should be wearing a mask. If they know they were exposed, they should be wearing a mask for the 10 days after the exposure. And if they've had COVID and they've left isolation, they should continue to wear their mask for the 10 days from when they were their symptoms began or when they tested positive. Beyond that, it's really going to vary based on what we're seeing and what the risk is. So, we have as general guidance for people that want more protection, for people say that are immunocompromised or live with someone who is, they can choose to wear a mask more often. For example, in crowded places, that would be the number one place you'd always want to wear a mask. I can say for our health department clinics, we've chosen to still require masks. So that our patients will feel more comfortable, and it is a healthcare setting. But that the mask rule about healthcare settings was a state rule, so there is going to be variation by healthcare facility, absent a new mandate coming back into place.
So thanks, Rima, and thanks, JD. There's another question talking about symptom screening. So we're seeing that some places are still doing that, some places are not. What are your thoughts about whether that's going to continue after the emergency, and the potential value or necessity versus unnecessity? I know that's not a word, but between those type of precautions and other types of COVID-19 precautions.
I don't know the answer if those are going to continue or not, but I think it raises a really important question that we've all been, in a sense, saying, which is May 11th is going to, it's next week. It's a week from today. It's not like COVID's going to be different on May 12th than it is on May 11th. And so, yet, I think the risk, a big risk here is that ending this emergency, which is being done for various reasons, signals something different. And it could lead to decisions to stop doing screening, stop making masks as available as they have been, stop taking steps to protect people, not based on actual changing data, but based on policy decision, which is only partly related to data. So, you know, again, I don't know the answer, and I think it's the other challenge is going to vary by jurisdiction, by facility. And so we're not going to have, not that we have had much of a consistent approach, but at times we've had more consistency. And I think we'll just have a lot less consistency. So it puts the onus on individuals, particularly those at risk, to try to navigate this very complicated landscape.
Thanks, Jen. Yeah, important points that basically, again, the pandemic is not over. So the emergencies are, but we still need to be vigilant and continue efforts. And speaking of the pandemic, well, of course, we're talking about the pandemic throughout this webinar. You know, there's the issue that the COVID-19 basically uncovered a lot of problems in the healthcare system and society that were there long before the pandemic started. And the concern is that a lot of these lessons haven't been learned. I think Jen and several of you pointed out in your talk, your presentations. And so now we don't have funding, like going back to like the return to normal, return to 2019 or before is not necessarily the direction that we want to go. And so Johanne and Danielle especially, what do you think needs to be done in order to make sure we don't just slide back to what things were like before 2020 and actually make these changes as a society to fill some of those gaps that were existing?
So I'm happy to start, and then I'll turn it to Danielle. You know, I think that's absolutely right. And actually, I think, through the pandemic, as people talked about a return to normal, my thinking is more that it's not so much about a return to normal, recognizing that everyone's definition of normal is very different and distinct. What I think it is again, having taking recognition of the experience that we all have been through and really moving forward in a way that says, there are things that we have to change, and they were changed, right, in the process, but we have to formalize some of those changes, and we have to continue to look at the opportunities to build on the changes that were made within health systems. We have significant challenges across the state and across the nation when it comes to healthcare access, and the systems of care and support that we offer to people. So now is the time, while we do still have some of the resources that are available to us, and while we certainly have the lessons that we have gained, for us to consider how we move forward and actually take that and move it into action. I think that consumers, if you will, of healthcare services certainly are in some ways much more educated on their own rights and their own spaces in which they can express their expectation. And I hope that that continues to happen so that we don't go back to the past, which didn't prove to be, initially exactly what we thought it was going to be if we were to experience a crisis to the amount that we did.
The only thing I would add to Johanne, just bringing the coverage perspective in again, is 3 years of continuous coverage, in my world, and I think our world, was wonderful. The fact that nobody lost health insurance for 3 years was great. And I think we are striving to see how we can move to, even though we're required to do these redeterminations, wherever we can extend continuous coverage or automatic redeterminations, we're going to do everything we can to make those permanent.
Thanks, Danielle. And JD, I think you have a comment.
Yeah, I wanted to specifically weigh in about something that we've never had, which is good care for complex chronic conditions. We could have single payer healthcare today, and I wish we did, but still not have what we need for complex chronic conditions like ME or long COVID that require a level of coordination, provider training, wraparound support that we see maybe the best case is of geriatrics, in some cases with sort of some of the complexities of HIV, but to the degree that we have millions of people in need of this care now more than ever before, we need to look at ways of financing and sustaining centers of care for fatigue, period. You know, no matter whether you had a positive COVID test, because many people didn't, no matter if you got your ME from Epstein-Barr or your Epstein-Barr was reactivated by long COVID. We use diagnoses as barriers currently a lot of the time. And what we need is to take away barriers and have care for humans who have bodies that have complexities. And there's many, many more of us since the COVID pandemic, and it continues. And that also includes children, where there can be the greatest complexities because children sometimes don't have the language to explain what's going on in their bodies because it's all relatively new to them. And they are the most frequently not believed. So children do get long COVID, and there's even less care for them. So I think we need to look at the kinds of innovations of care and systems of care different than we did for HIV, but with a similar level of commitment to figuring out how to do things differently.
Important words, JD. I think, you know, forward-looking and really figuring out how we can solve these problems is very important. We're actually at the end of the half hour or the hour and a half. Would love to continue this conversation because we have lots of questions in the chat, but unfortunately we're hitting the limits of time. I see a lot of questions about whether things such as like free masks will be available or testing kits, et cetera. And I think one of the challenges right now is it's unclear because if a lot of the funding dries up, when, you know, the emergency declaration funding dries up, then the big question is who's actually going to pay for a lot of these things that were available. So we're in a situation where, you know, the public has gotten used to a lot of services and products being available, and that might end after May 11th. So there's no clear answer with that. And I think Rima mentioned in her presentation that it's really key to check with your insurance coverage, or wherever you're getting funding or support for your healthcare. And in many cases, the answers will lie in that. But it's very important to remain vigilant and also pay attention to all the websites that were provided by the New York City Health Department, by New York State, or wherever you may be located. Federal websites, of course, but if you're located in a particular state or municipality, you need to pay very close attention to what will be available and what will be offered, because it's going to be a bit of a mishmash, patchwork quilt going forward. So that being said, I would like to thank all of our panelists again. You know, your expertise, your experience, your background, and your insights are very valuable, and you've provided really important information. And I'd also like to thank Bashar Mackay, who's been helping in behind the scenes put on this webinar. So thanks again for your technical wizardry. Wanted to thank others like Danielle John and Sarah Rebert for their efforts, their communications efforts. And I wanted to give Danielle Green an opportunity to say hello. She's our Chief Operating Officer for our Pandemic Response Institute. Danielle, do you have any closing thoughts or comments?
I honestly don't think I could say anything better than our panelists have said it. And this is such an important topic, particularly how do we go forward with fewer resources and ongoing need and aim to do this in the most equitable way and protect the most vulnerable while hopefully reducing some level of stress for everybody, because we all have been in a heightened level of stress for so long, and that has also taken its toll on all of us. That we need to be vigilant and we need to care for each other. And I just think our panelists said it all so well. And thank everyone for coming and joining us today. PRI will be doing a lot more of these webinars.
Thanks, Danielle. And I want to add that Danielle, you know, before her becoming the Chief Operating Officer for the Pandemic Response Institute, you know, she's worked at in the New York State government as well as the New York City government, so has extensive experience and perspective regarding just public health in general, and also regarding the COVID-19 pandemic. So once again, I wanted to thank all of the panelists and everyone also behind the scenes who helped put on this webinar. I wanted to thank everyone who joined, who tuned in, and thank you for all your thoughtful questions. Once again, we apologize. We couldn't get to each and every question because we have this limits of this thing called time, but this is also the start of a discussion. Our PRI continues to be very active in terms of pandemic response, pandemic preparedness. We're going to have more webinars, more activities. So stay tuned, check our website, our PRI website, look for future activities and initiatives, and looking forward to continuing the discussion and the conversations and moving forward. Again, we don't want to go back to how things were before 2020. We want to take the lessons learned, and we want to continue to improve our society in general. So thanks everyone, and have a good afternoon.